My name is John Farley. I am a GYN oncologist associated with Dignity Health Cancer Institute here in Phoenix, Arizona, in association with the Creighton University Medical School. And I am honored to be here today, invited by the Ovarian Cancer Research Alliance to talk to you about rare ovarian cancers. And so the ovarian cancer burden in the United States is very significant. Where in 2025, we can expect approximately 20,000 new cases with about 13,000 deaths. We generally define rare tumors in the United States as those tumors having less than 3,500 cases a year. And for ovarian cancers, this includes sex cord stromal tumors, germ cell tumors, and some rare epithelial tumors that I will talk about. The diagnostic problems we have with these rare tumors are much the same as we have in general with ovarian cancer, is that they tend to be found at a later stage. They can have vague symptoms. And also, unlike traditional, what I'll call high-grade serous cancers, which I'll talk about in a little bit, there is a low awareness of these kind of rare tumors and their differentiation from the more common histologic ovarian cancer. And as a result, a lot of providers don't necessarily have much experience with these cancers. And so we can kind of divide ovarian cancers into three general categories. One category is the epithelial tumors. And for simplicity's sake here, we'll say that these tumors originate from the covering or the epithelium of the ovary. And the histologic subtypes for these cancers include serous, mucinous, endometrioid, and clear cell carcinomas. We then have the sex cord stromal tumors, which are originating from the connective tissue of the ovary. And they will include the Sertoli cell tumors and adult granulosa cell tumors. And then finally, we have germ cell tumors, which are tumors that are derived from the eggs in the ovary. And these include yolk sac tumors and dysgerminomas of the ovary. So, in general, the epithelial or the covering of the ovary tumors make up the majority of ovarian cancers. And you can see here it's about 85%. Sex cord stromal tumors make up about 7%, and then germ cell tumors make up about 6%, as you can see here. If we look at the breakdown of epithelial tumors in general, you can see here that clear cell and endometrioid carcinomas make up about 10 or 9% of ovarian cancers. We generally consider endometrioid and clear cell carcinomas as cancers that are associated with endometriosis, which is a benign condition we think originates from the uterus. And then finally, we'll talk a little bit about low-grade tumors, again, which make up about 10 to 12% of ovarian tumors in general. And here you can see kind of a breakdown of the individual different types of both the germ cell tumors uh, and the sex cord stromal tumors here. One of the big problems we have in dealing with cancers in general, ovarian cancer specifically, is the vast lead time that you have from the development of drugs in a laboratory until it gets approved for treatment for our patients. And as you can see here, the attrition rate with the ideas that we have as far as treating a cancer in general, again, ovarian cancer specifically, is very significant. We start out with tens of thousands of ideas or compounds that are developed in a laboratory by industry or by individual institutions. And as we go along the way from preclinical trials in which these medications are tried in cell lines, and then after that, they're tried in animals, rats, things along those lines. And then we move on to clinical trials, the different phases of the trial. Phase one trial, which looks at the toxicity of an agent. Phase two trial, we take the types of cancer that had a response to the medication in phase one and then specifically treat that in phase two. And then if we see a signal in phase two, we further test the medication in a randomized phase three trial to see if it's better than the standard of care. And if it turns out to be better than the standard of care, that drug gets approved by the FDA and then it's able to be used on our patients. And so, again, you can see the high attrition rate for this and the almost 20 to 30-year lag time between the time that we have an idea and the time that it might be ready for our patients. So, again, this can take a significantly long time to come up with an idea. And I go into that because, as you will see, for many of these cancers, or I think the majority, about 80%, a lot of them are more recently being treated with targeted therapies, immunotherapies are the kind of the new kids on the block, and it's taken us a long time to get there. I'm going to start off talking about low-grade serous carcinomas of the ovary. I think that you will have a much more, or you've had a much more advanced talk regarding low-grade serous carcinoma specifically. So I will not necessarily spend a lot of time on these tumors. And so histologically, low-grade tumors look different. They're a little bit more formed, look a little bit more like glands than kind of the haphazard, aggressive high-grade serous carcinoma. And high-grade serous carcinoma is when patients or the general public thinks of ovarian cancer, what they're really thinking about and what they're referencing is a high-grade serous carcinoma, which, as you had seen previously, is the majority of ovarian cancers. Low-grade serous carcinoma, again, 10 to 12% of ovarian cancers, and they are diagnosed based on a two-tier staging system developed by MD Anderson. Initially, when I first started training, we graded cancers into grade one, or serous cancers into grade one, grade two, and grade three. However, MD Anderson went and reviewed hundreds of histologic specimens and found that there was really not much validity in differentiating between grade two and grade three. They both behaved the same. They both responded to treatments in a similar manner. And therefore, we came up with a two-tiered system in which somebody was either low grade, grade one, or somebody had a high grade cancer. Now, there are clinical and molecular differences with regard to low grade and high grade cancers. As I stated previously, the low grade cancers tend to have milder atypia, less mitosis, and look less aggressive. They will occur at a younger age compared to high grade serous carcinomas. They tend to have an indolent course, which means they're not very aggressive as far as their growth rate, but because they are not fast growing, quote unquote, they tend to be very poorly responsive to chemotherapy because chemotherapy relies on the fast division of cells to be the most effective. And so, unfortunately, these low-grade tumors tend to be chemo resistant. And the molecular alterations, which we will go into in depth, more with the MAP kinase pathway, with KRAS and BRAF mutations, popularized in the treatment of melanoma and colon cancer, again, tend to be altered in low-grade serous carcinoma, as opposed to the molecular alterations we see in high-grade serous carcinoma, which have to do with the BRCA mutations and hereditary ovarian cancer, and also P53 mutational status. Again, found in high grades, we don't see BRCA mutational status or hereditary ovarian cancer at a similar rate, only a couple of percentage in the low grade histotype. Now, there are two ways for someone to develop a low-grade serous ovarian cancer. One is a de novo development of low-grade serous carcinoma. Another is to have a serous borderline tumor, which is a similarly non-aggressive tumor of the ovary, which is slow-growing and indolent and generally can be cured with surgery, not requiring any subsequent adjuvant therapy with chemotherapy or radiation therapy. And for that serous borderline tumor to recur as a low-grade serous carcinoma. And you can see here, looking at the survival rates, although here we see the survival for serous borderline tumors, which is again is fairly excellent compared to low-grade serous carcinomas, we see the contrast, however, when the serous borderline tumors recur as low-grade serous carcinomas, the survival for the two groups are essentially the same. And so If you have a borderline tumor and it stays a borderline tumor, very good prognosis. However, if it tends to recur and it recurs as a low grade serous carcinoma, you unfortunately have the survival, a poor survival that is associated with low grade serous carcinomas. I stated previously that unfortunately low-grade carcinomas are fairly platinum resistant. An initial trial looked at a randomized phase 3 fashion about various triplet chemotherapies in the treatment of advanced stage ovarian cancer. And it looked as a baseline looking at carboplatin and paclitaxel against a variety of triplets that included topotecan and Doxil and a variety of other agents. And they did a subset analysis in this study in which they broke down patients by low grade and high grade cancers in those patients who received the chemotherapy. And there wasn't really any difference in the groups when they divided them, except again, as you can see here for age, as I stated previously, low grade serous carcinomas tend to occur at a younger age than high grade serous carcinomas. But other than that, the groups were fairly well matched. And what we can see here looking at progression-free survival is the top two curves are each subset for patients who had all their cancer removed, which they had non-measurable disease after surgery. The bottom two curves are patient groups which had visible residual disease after surgery. And you can see that for low-grade serous carcinomas that are here, the median progression-free survival of 33 months was much greater than that for the high-grade serous carcinoma, meaning surgery had a significant impact. However, when we look at the bottom two curves, essentially for both low-grade and high-grade cancers, if there is residual disease, the progression-free survival is significantly worse at around 14 months. The reason why cancer cells develop resistant to platinum or any other chemotherapy are myriad. They can have to do with either stopping the medication from entering the cell, they can alter and push the medication out of the cell faster than it enters it. And then also, it can alter the mechanism by which the chemotherapy destroys the cancer cell. The way that platinum agents destroyed cancer cells by binding to the DNA and inhibiting replication of the cell. However, if the cell develops ways to repair the DNA damage after it's been caused by the platinum, it won't cause cell cycle arrest. Additionally, we have a variety of immune factors in the tumor microenvironment which can assist the cell with regards to DNA repair and DNA damage and kind of flip the cell from cell death into cell life. And these are all mechanisms which we can encounter with regards to platinum resistance. When we look at overall survival of that study, we just looked at, again, for those patients who have no measurable disease and are low grade, they have excellent overall survival, 96 months versus 71 months that we see with the high grade serous carcinoma who have no residual disease. Again, we see that if there is visible residual disease left, that the overall survival for both low grade and high grade are fairly similar at 42 and 37 months. Because of the lack of effectiveness of chemotherapy in treating these low grade serous carcinomas, we sought to investigate whether targeted therapies might be more effective. And the first trial to look at this was GOG 239, in which patients with recurrent low-grade serous carcinoma were given a MEK inhibitor, which alterates the MAP kinase pathway. Previously, I talked about frequency of mutations in the MAP kinase pathway, both the KRAS and the BRAF mutations. And so we sought to exploit that, giving this oral treatment for 4 weeks. What we found is we had a significant, almost 15% response rate and an almost 80% disease stability rate in the recurrent setting for these medications. We also saw that almost 30% of patients received 10 or more cycles of this treatment without progression. So significant help to these patients. Here again, we see both the overall survival and the progression-free survival for this medication, with progression-free survival approaching 24 months for this subgroup. At the time, we went back retrospectively and looked at two different cohorts of patients who had recurrent low-grade serous carcinoma and treated with hormonal therapy and chemotherapy. And we found that the MEK inhibitor, indeed, looking retrospectively, had a better response rate and progression-free survival than those other therapies. Here, you can see that the response rate of 15%, much greater than the 3 and 9% response rate we see with the either the chemotherapy, the hormonal therapy, much higher clinical benefit of almost over 80%, and then a much higher progression-free survival than those other medications. So again, at first blush, it appears that inhibiting the MAP kinase pathway will be effective in these tumors. Because of this observation, we went to further testing, looking at a MEK inhibitor, another MEK inhibitor, trametinib, in a randomized phase 2-3 trial comparing trametinib versus physician choice in the treatment of low-grade serous carcinomas. This was a randomized, a multi-center phase 2-3 trial, again, looking at oral trametinib at 2 milligrams versus Taxol or liposomal doxorubicin or intravenous topotecan or oral letrozole. And what we found was that there was a significant increase in progression-free survival. The single agent trametinib significantly doubled progression-free survival from the 13 to the 7th months. The response rate was vastly increased from 6 to 26%, and the overall survival was increased by almost 8 months in this study. And here you can take a look at the Kaplan-Meier curves. You can see here that the comparison of the MEK inhibitor versus standard of care increased median progression-free survival by 13 months compared to 7.9 months. And then also, when we look at the MEK inhibitor versus hormonal therapy, which is the letrozole, we can see again that the median overall survival was increased from 10 months to 15 months in the MEK inhibitor group. So success on both comparisons. This was a fairly well tolerated medication. Common side effects included rash, anemia, and hypertension. There were no very severe grade 5 toxicities associated with the medication. And although those medications were made in approximately half of the patients, the toxicities were manageable and they did not require the patients to come off study. If we look at the cost of the medication, it sought to trametinib extended quality adjusted life years by approximately a half a year, 0.58 years. There was a cost of $248,000 for this increase in life. Therefore, the incremental effectiveness ratio of this medication of $424,000 is slightly higher than 100 to 150,000 quality that we normally look for. However, in continued development of medications and MEK inhibitors and implementation of this on a wide range scale, hopefully we'll be able to continue to bring that ICER down. Now, what about combination therapy? I've been talking about single agent MEK inhibitor therapy previously. Now, what if we put two medications together? One targeting the MAP kinase pathway, and the other one which targets the FACT pathway, defactinib. And so what we did in GOG 3052 is we looked at whether the combination of these two agents, defactinib and avitametinib, was better than the MEK inhibitor alone, which was kind of the trials which I just showed you using single agent MEK inhibitor. And what we also did is that we stratified them by KRAS mutational status. And what you can see here is that overall, the combination of treatment using the two agents had a much higher overall response rate, 33% versus 17% in the patients that treated. And if we stratify by RAS mutational status, we see a much greater response rate, 44% response rate in the RAS mutant patients for the combination compared to 23% for the single agent MEK inhibitors, which is kind of what I had showed you previously with those other agents, different medications from different drug companies. And so you can see that the combination therapy, again, appears to have a much higher response rate. And again, looking at the Kaplan-Meier curves, we look at the duration of response. We see here for the combination, we can see that the duration of response is approximately in the median of 31 months. Here you see for all patients here, again, 31 months. And then to the KRAS wild type patients, only 9.2 months. And then looking at progression-free survival, again, the top line, the better performing line being the KRAS mutant patients, having a 22-month progression-free survival. And looking at the all comers and also the KRAS mutant, the progression-free survival was only about 12 months, or 12.8 months or 12.9 months in those subgroups. Finally, looking at the waterfall plots, if you just concentrate on the blue lines, anything below the horizon is considered a response. Anything above the horizon is considered progression. And you can see how a lot of blue lines are seen in the study, indicating a response to the combination treatment. So again, very effective medication. And in fact, the combination of the two, the MEK inhibitor and the FAK inhibitor, was FDA approved for the treatment of recurrent low-grade serous carcinomas, particularly KRAS mutated tumors recently. So we have another option in our armamentarium. So in summary, for low-grade serous carcinomas, it appears the MAP kinase pathway is important in the diagnosis and treatment of disease. MEK inhibitors continue to be the backbone of the paradigm in treating these cancers, and it's essential to integrate biomarkers and molecular stratification of these cancers. In the future, we need to do more prospective biomarker trials in order to continue to identify newer agents and predictive markers of response to therapy for these targeted therapies. I'll next move on to sex cord stromal tumors. Again, sex cord stromal tumors are tumors that develop from the connective tissue of the ovary. They only comprise about 5 to 18% of all ovarian tumors, and the most common are granulosa cell tumors. And we'll talk about adult granulosa cell tumors here. There are juvenile granulosa cell tumors. However, they are a pediatric cancer. And we'll talk about Sertoli-related cell tumors. They most often occur in women who are age 50, 60, but can occur in any age. And while the prognosis for early stage is very favorable, advanced or recurrent tumors can be a challenge. Initially, the treatment for cancers is surgery. Because of the increased percentage of patients who present at an early stage, should young women desire preservation of their fertility, it is possible just to remove the cancer if it looks like it's confined the one ovary and leave the other ovary in the uterus in order for women to complete childbearing. Debulking surgery may be necessary in patients with advanced disease. Again, this is in a lower percentage of patients, only about 15%, 20% will present with advanced stage disease requiring debulking. And if that's necessary, we can do that. Chemotherapy, and we'll go into it specifically, is generally reserved for patients who have advanced stage or recurrent disease. Carboplatin paclitaxel, as in high-grade serous carcinoma, is the backbone for treatment of these cancers. In some instances, we can use chemotherapy neoadjuvantly prior to surgery as a treatment for these cancers. And if patients develop resistance to platinum-based agents, there are other agents we can potentially try. Hormonal therapies remain a very viable treatment for these cancers. Any anti-estrogen agent, whether it be progestational agents, aromatase inhibitors, and tamoxifen that are used in breast cancer more commonly, or estrogen receptor modulators, all can be used and all are effective in treating these cancers. Radiation therapy, unfortunately, has a limited use with regards to the treatment of this cancer and is generally used for isolated recurrences. Now, because chemotherapy tends to be effective, we looked at and saw whether the combination of chemotherapy and hormonal therapy might be effective in recurrent granulosa cell tumors. And we looked at it in a phase 2 trial, combining carboplatin with letrozole in the treatment of recurrent granulosa cell tumors. And what we found is that there was a very high response rate, 50% of patients responding, with 20% of patients getting a complete remission using this medication. And as a result, the potential combination of chemotherapy with hormonal therapy is a viable alternative for patients who have recurrent granulosa cell tumors. Now, what about more modern medications? If we look at immunotherapy, immune checkpoint inhibitors, and here we'll start with pembrolizumab, what we see is an initial trial looking at very few patients, approximately 5, in a phase 2 fashion, did not find very much success in patients with advanced and recurrent sex cord stromal tumors. There were no response rates that were observed in this group, and therefore this initial trial wasn't as successful as we like. We, however, progressed and tried a different trial looking at a different agent, another checkpoint inhibitor, anti-PD-1 inhibitor, nivolumab, in the treatment of recurrent or metastatic sex cord stromal tumors. And the goal was looking at progression-free survival. And interestingly, what we found is that there was a partial response rate observed in 30 to 40% of patients with granulosa cell tumors with progression-free survivals from 6 to 12 months. And some patients experiencing very durable responses to this medication. And so this indicated that there might be a window for the treatment of these granulosa cell tumors with an anti-PD-1 inhibitor. It showed promise in treating granulosa cell tumors, and some patients again had a long-term durable response on this treatment. There are very few immune-related side effects associated with the treatment, and we sought further studies to evaluate checkpoint inhibitors in the treatment of these cancers. The next step, again, was combination therapy. And so we looked at combination immunotherapy, looking at nivolumab, again, which is an anti-PD-1 inhibitor, combined with ipilimumab, which is anti-CTLA-4, another immunotherapy medication. And in the single arm phase 2 trial, we found that the response rate, looking at recurrent sex cord stromal tumors, the response rate for granulosa cell tumors was 25%. And here again, we're looking at the waterfall plots. Again, the horizon here, below the horizon responses, above the horizon progression. If you look at the granulosa cell tumors in red, you can see that we have significant responses here. Further, if we divide, and carcinosarcoma is another rare tumor, we see that unfortunately immunotherapy is not very effective in the treatment of carcinosarcomas, as with general high-grade serous carcinomas, where immunotherapy doesn't tend to be effective. But if we look at granulosa cell tumors, again, we see that below the horizon, that granulosa cell tumors have a significant response rate in the treatment with this combination therapy. When we look at the duration of response, we can see in red, the granulosa cell tumor patients experience a significant progression-free survival on this combination regimen. And we break it out here again with granulosa cell and carcinosarcoma and see the impressive duration of response rates. Over half of patients with the responses over 20 months, as we see here in the granulosa cell tumor cohort. So very exciting. The Kaplan-Meier curve showing progression-free and overall survival going out 5 years for patients in this study. So again, very exciting for treatment of refractory granulosa cell tumors with 25% of patients experiencing responses that lasted 4 years or more. So very exciting for the immunotherapy combination. Now, what about targeted therapy? Looking at the tumor microenvironment and specifically targeting the VEGF, vascular endothelial pathway, of which bevacizumab is kind of the main agent that we use. Single agent bevacizumab in recurrent sex-cord stromal tumors showed a 17 response rate. However, 78% experienced stable disease with a progression-free survival of over 9 months. Because of this, we sought to, again, single agent works. We look at combination. We combine bevacizumab with chemotherapy in a randomized phase 2 fashion, looking at Taxol alone or Taxol with bevacizumab. And although the response rate for Taxol was much greater than single agent Taxol, unfortunately, the progression-free survival for each, the combination versus single agent, were similar. So, although good response rate, not much difference in the progression-free survival. So it appears that combination therapy with Avastin and chemo doesn't offer much benefit. And so you're going to get copies of the slides, and so you'll be able to investigate the summary more closely, but we can see that treating of sex-cord stromal tumors with chemotherapy in the frontline setting, very much successful, 70 to 90% response rate in the frontline setting. In the recurrent setting, chemotherapy response rates vary from 20 to 30%. When we look at hormonal therapy, again, using hormones in small numbers of patients, the response rates can vary from 80% to 100%, given the type of therapy and the prior treatment that they've had, and some novel therapies looking at different targeted pathways in very, very small amounts have case reports have shown some response to these agents. We are excited. The NRG recently finished a randomized phase 2 trial looking at an androgen receptor inhibitor in combination with Lupron and a hormonal agent and an aromatase inhibitor in the treatment of granulosa cell tumors. This trial has finished accrual. It's currently being analyzed, and hopefully we will have some results regarding this triplet therapy to see if there's something else we can add to our armamentarium for granulosa cell tumors. I'll next move over to germ cell tumors. Again, we talked about the histologies here. The management of germ cell tumors, because they're so rare, is mainly based on testicular cancers because they're common, and we extrapolate from that. The majority of patients are diagnosed as stage 1, and as with sex-cord stromal tumors, unilateral salpingo oophorectomy, sparing fertility is a viable option. And if you looked at patients who had disease apparently isolated to the ovary, comparing survival for fertility sparing versus non-fertility sparing, their overall disease-free survivals were similar. Adjuvant therapy for these cancers tends to be treated with platinum-based regimen. Most common we use are bleomycin, etoposide, and cisplatin. Who do we treat? Who do we offer treatment to? For dysgerminomas and immature teratomas, if they're early stage and not very aggressive, you don't have to treat them. If they're early stage and a little bit more aggressive, it's kind of a discussion with the patient. There is a very low relapse rate, and so it's not unwarranted to observe these patients. However, all patients with yolk sac tumors and those patients with advanced stage 2 to 4 dysgerminomas or immature teratomas should be offered chemotherapy treatment. And here we see kind of a summary again of agents looking at recurrent germ cell tumors and different agents that we've used to treat them. And at first blush, you can see we haven't had much success in the recurrent setting, whether it's with different types of chemotherapy. When we look at from a molecular setting, again, inhibiting the VEGF pathway with a variety of agents. We see no response rates, no complete responses, minimal responses, and the duration, progression-free survival in months here, 2 months and 1 month. When we look at inhibiting a different pathway with the mTOR inhibitor, we see again no responses and progression-free survivals within weeks or months. We look at PARP inhibitors, which our treatment can be offered treatment in higher grade serous carcinomas. Again, no responses and progression free in months. And then looking at medications, the CDK inhibitors, which are treatment paradigms in breast cancer. Again, we're looking at weeks as far as progression. So nothing very successful in the treatment of these cancers. We progress to more modern occasions, thinking perhaps immunotherapy might offer us a option with regards to the treatment. And again, we fall flat with regards to the treatment of these recurrent germ cell tumors. No response rates, one maybe partial response, very small progression-free survivals measured in tenths of months or months. So not very effective. So targeted therapies, VEGF pathways, immunotherapies, all not very effective in treating the recurrence of the cancer and germ cell cancers. And so we have to fall back on old, quote unquote, traditional chemotherapy. And the general concept is that any platinum containing chemotherapy in the recurrent setting can be effective, whether it's cisplatin or oxaliplatin or carboplatin in combination with gemcitabine. Here we're seeing response rates around 50% and overall survival going out to 13 weeks. And so, unfortunately, modern medications, at least to date, haven't been found as effective in treating recurrent germ cell tumors. And we have to jump back and rely on traditional chemotherapies, which should be platinum based in the treatment of these cancers. Next, we'll look at clear cell ovarian cancers. Again, clear cell and endometrioid, you can kind of interchange these, are considered endometriosis associated ovarian cancers. We think that these cancers develop from endometriosis, which is a very common benign condition that can be found in women. However, there are a percentage of patients who have, of endometriosis patients who have a specific molecular abnormality mutations in the ARID1A gene, and we'll talk about that in a little bit, which we think allows them to progress to these cancers. They are a rare cancer, less than 10%, and they're poor prognosis for advanced stages of these cancers. And again, as I said, the adjacent endometriosis may harbor mutation. And because of the effect on the VEGF pathway and a HIF1 alpha, these tumors can be have a tendency to cause thrombosis and deep venous thromboses. Clear cell carcinomas tend to be refractory to chemotherapy as a role. Here we look at a retrospective study looking at approximately 6 randomized phase 3 trials in advanced ovarian cancer, which were conducted by the Gynecologic Oncology group. We grouped all those studies and analyzed by histology. And what you can see here is that the progression-free survival for clear cell carcinoma is much less than that for high-grade serous. And the overall survival, again, significantly less for these advanced stage ovarian cancer patients treated with chemotherapy when we look at clear cell versus their high-grade serous counterpart. Very different molecular difference in these tumors. As you saw previously with the low-grade serous carcinoma, the high-grade serous have altered p53 mutation. They tend to have deficiencies in the homologous recombination DNA and or BRCA mutations contributing to this. They have very few mutations in targetable pathways. And this compares again to the clear cell, which tend to have copy number alterations. Their deficiencies with regard to homologous repair are much smaller, anywhere from 6 to 21%. It can occur, but they have frequent alterations in different pathways that we potentially could be able to target. Now, clear cell carcinomas themselves can be a heterogeneous cancer, and tend to be divided either into ARID1A mutated tumors, which tend to have a better prognosis than their wild type counterparts, or P53 mutated tumors, which make up only about 17%. And those tumors tend to behave more like the classic high-grade serous carcinomas than traditional clear cell carcinomas. Here, as we can see, a retrospective trial looking at the response of clear cell ovarian cancers to platinum-based chemotherapies. Here we see that the response rate for clear cell carcinoma was only 11% to platinum-based therapy, as opposed to 72% in those patients who were high-grade serous carcinomas. However, if we alter it a little bit and use gemcitabine as one of the chemotherapy agents rather than have it platinum based with a platinum and taxane, we see that we can get a significantly higher response rate in the recurrent setting for clear cell carcinomas with an overall response rate of around 61%, again, comparing to the 11% that we saw with traditional platinum and Taxol. And we also see that the gemcitabine is very effective in those patients who do not have an ARID1 mutation. And so, interesting preliminary data, which hopefully we'll be able to continue to investigate and confirm the effect of gemcitabine in the recurrent clear cell population. Again, we talked about the variety of altered pathways in clear cell carcinoma, the HER2 pathway, more common in breast cancer. There are new antibiotic drug conjugates, trastuzumab deruxtecan, which could be effective in the treatment. We look at the mTOR pathway. Unfortunately, early on, we did a randomized phase 2 trial looking at temsirolimus, which was mTOR inhibitor, and we did not see any clinical difference in the addition of temsirolimus. And then finally, we get back to our old friend, the MEK pathway, looking at KRAS and NRAS mutations. And so perhaps MEK inhibitors might be effective in the treatment of these cancers. Probably the most common and targetable pathway has to do with the ARID1A pathway, which occurs in some studies over 50% of clear cell ovarian cancers. And so, in a setting of ARID1A deficiency, a variety of medications or inhibitors could be tried to see if they might be effective in clear cell ovarian cancers. And that's what we sought to do. First, we sought to inhibit the Swin-Swift chromatin pathway, which is the pathway which uncoils the DNA and prepares it replication. And we looked at a medication which inhibited this unwinding of the DNA in a phase 2 trial. And unfortunately, we didn't find very promising results. Only a 4% response rate, 2% complete response rate with a PFS of only 2.1 months. And so what about other, again, I showed you a variety of pathways with the Swin-Swift pathway, multiple agents that we've tried, a kinase inhibitor, more EZH2 inhibitors, ATR inhibitors, and again, just not the performance that we would like with these single agent medications in the clear cell ovarian cancer cohort. There are other variety of trials, again, because of the multiple pathways that can be affected in clear cell ovarian cancer, which patients can be eligible for, and which we are excitingly waiting those results. When we look at targeted pathways, again, looking at anti-angiogenesis, bevacizumab, and the HIF-1 alpha pathway being kind of the preferred agents, we see that with other agents, single agent therapy with either sunitinib, cabozantinib, or ENMD 2076, response rates, again, overall response rate of 0 to 17%, and only less than 25% patients remaining progression-free after 6 months. So as a single agent, VEGF combinations, not very effective in recurrent clear cell ovarian cancer. Well, what about combination? And here is where we start to see some life. We start to see some effectiveness in the treatment of this disease. And so if we combine bevacizumab with first-line chemotherapy in the treatment of clear cell ovarian cancer, we see a significant increase in progression-free and overall survival in the treatment of this cancer. Additionally, when we look at an immunotherapy combined with bevacizumab in recurrent or persistent clear cell, again, we see a high response rate of 40% with a complete response rate of 14%. Very exciting, very promising. And we'll talk about combination immunotherapy, again, with an overall response rate looking very promising. And here again, we see the waterfall plots looking at the combination of pembrolizumab and lenvatinib. And again, everything below the horizon is a response. So you can see the combination of immunotherapy and targeted therapy appears very exciting in the treatment of this disease. Now, as a further elucidation of immunotherapy combinations, we looked at the combinations with targeted agents and both the combination between PD-1 inhibitors and CTLA-4 inhibitors, again, which I have talked about previously. And we found some very exciting news in a variety of trials looking at these combinations, with response rates varying from 20 to 33%, which almost 15 to 20% of patients experience a complete response. Here we're looking at Nivo and ipilimumab in two trials. We're looking at another company's PD-1 inhibitor and bevacizumab, 40% response rate. And again, pembrolizumab and lenvatinib, and being a targeted therapy for VEGF, looking at a 44% response rate with a 65% of patients remaining progression-free at 6 months. So very, very exciting. This is just kind of a summary of those combinations that I told you about. And again, impressive response rates, anywhere from 20 to 50%, looking at these combinations, particularly Nivo and ipilimumab. And again, fairly well tolerated. There are some immune-related adverse events, but most were controlled with adjustment of the dosage of the medications that we gave. The mechanism by which immunotherapy and checkpoint inhibitors is beneficial with regard to clear cell ovarian cancer remains to be elucidated. We're still working on finding that. We need to continue to identify predictive biomarkers with regard to our patient selection. Perhaps it is a marker PP2R1A mutation, uh, which could predict this, and we'll talk about it in a little bit. However, the simple looking at the PD-L1 status within a tumor does not, unfortunately, predict response rate to these combinations of therapy. There are still other medications that we can try. I talked to you about here too, an antibody drug conjugate in these tumors, perhaps tissue factor, which is overwhelmingly expressed in over 95 to 100% of these tumors. Tissue factor inhibitor Tivdak, currently approved for the treatment of cervical cancer. So perhaps we can uh, test that agent, see if it's effectiveness in the treatment of clear cell ovarian cancer, and then MET inhibitors and overexpression. In summary, clear cell ovarian cancer has a unique biology. It has a variety of oncogenes and pathways which are altered in this disease, which we hopefully are able to exploit. Immunotherapy combinations appear to be very promising. However, we have to be careful. Ovarian clear cell carcinoma is not a singular disease, and molecular subclassification can be very beneficial. And that brings us to the final subject of my study, and it is a success story. And this is the PP2R1A mutation in gynecologic cancers. It occurs in approximately 10% of clear cell ovarian cancers, and it again can occur in serous and carcinosarcomas and with regards to other tumors. And this mutation appears to be very sensitive to immunotherapy. So what our colleagues did was looked at recurrent clear cell ovarian cancers and then stratified them by PP2R1A mutation status, and looked at the effectiveness of treatment with combination therapy with anti-PD-1 and anti-CTLA-4 treatments. And what they found was fairly significant. First, we found an increase in overall survival of 66 months versus 9.2 months in those patients who had recurrent clear cell ovarian cancer. Between those who are PP2R1A mutated, 66 months overall survival compared to those who were negative for the mutation treated with immunotherapy. As would be expected, we found that patients with the ARID1A mutation status did better than those patients who did not. But again, if we stratify those patients with ARID1A mutations who have the PP2R1A mutations, we can see that even in that good prognostic group, we see that the PP2R1A mutation has a significant better overall survival. Again, 67 months versus 9.2 months. So very exciting data. Here you can see just some overall pictures looking at disease stabilization and disappearing in patients treated with immunotherapy throughout their treatment. Again, looking at the waterfall plot, when we look below the horizon at those patients who response rate, we see that the orange patients, who are the mutated PP2 RNA patients, are significant in this response group. Now, because of the exciting data that they found with clear cell ovarian cancer, they extended the study retrospectively and looked at all of the cancers treated at the cancer center with immunotherapy and stratified them by PP2R1A mutational status. And again, they found some very exciting results. When you look at all the patients treated with cancer, again, those patients who had PP2R1A mutation had a significant better overall survival, at least 80 months compared to 18 months in those patients without any PP2RNA with status. And to confirm that the effect on these cancers was the immunotherapy, they also did a cohort looking at overall survivals for cancers treated with just chemotherapy, not any immunotherapy, and stratified them by PP2R1A mutation status. And there was no difference in overall survival in those patients treated with chemotherapy. So this confirms that the PP2 RNA mutation status makes patients exquisitely sensitive to immunotherapy who might be previously refractory to traditional chemotherapy. When they further looked at other specific cancers, again, we see for lung cancer, those patients who had two R1A mutations did very well compared to those who weren't mutated. Looking at melanoma, again, was 75% overall survival probability compared to 18% in those patients who aren't PP2 RNA mutated. And looking at another gynecologic cancer, uterine high risk uterine cancers, we can see that the overall survival, approximately 40 months in those patients who are mutated compared to 20 months in those patients who aren't mutated, and a difference in progression-free survival of 7.5 months versus 5.5 months in the mutated patients treated with immunotherapy. So in conclusion, there appears to be a significant correlation between loss of function of this gene, the PP2 RNA mutations, and improved overall survivals, not only in patients with clearly recurrent ovarian clear cell carcinoma, but other patients treated with immunotherapy, checkpoint blockade combinations. The presence of this mutation appears to enhance the response to immune therapy in the tumor microenvironment. And importantly, the PP2 RNA mutations are not associated with increase in overall survival for those patients treated with the traditional cytotoxic carboplatin and paclitaxel chemotherapy. And the results of this study suggest that this mutation perhaps can be a predictive biomarker for the use of immunotherapy, immunocheckpoint blockade in the future. I would like to thank you for the opportunity to talk about rare ovarian cancers, and I'm honored to have given you this presentation.